Well, I'll be back in just a second,
Yeah.
please. Jamie, what do you want to do about questions?
So what I'm going to do is tell everybody that they can put questions into the Q&A and I will monitor it. And however you feel comfortable with answering it during or pausing or at the end is completely up to you.
Maybe we'll hold them off to the end if that's all right. If there's
Perfect.
absolutely burning
Yep.
questions, we can get that. As I indicated, I got quite a few slides, so I want to try and get through as much content and get to some of the videos but I'm happy to answer as many questions as I can. Okay.
Perfect. Sounds great. Thank you. Good afternoon, everybody. Welcome to our webinar from Dr. Orange about communication techniques and strategies. We're just going to wait another minute to allow for other individuals to join the webinar. Okay, well, good afternoon, everybody. My name is Jamie Cruz, and I am the Public Education and Community Programs Manager with the Alzheimer's Society of York Region. And I am honored to introduce Dr. Orange, who is going to be presenting today about communication techniques and strategies across various types of diagnosis with dementia. Before Dr. Orange does present, I am going to be sharing some information about a phenomenal program that all of our societies, 26 societies of the Alzheimer's Society, that we do present about finding your way. And this is really crucial and important because it's about how are we going to keep individuals in our community safe and protected. So finding your way is about how are we going to really help individuals who are living with dementia, as well as their care partners, feel safe in their community? How are we going to recognize when somebody is at a risk of going missing? And how are we ourselves going to prepare for when these missing incidents happen? How are we as a community going to make sure that our community is safe for each person and each care partner? Dementia is an umbrella term that we use to describe a series of symptoms associated with a diagnosis. There are so many different types of dementia, and we use an umbrella term because it represents the different spokes on the umbrella represent a different diagnosis. And as you can see here under the umbrella, the most common types of dementia are being described here. So Alzheimer's disease represents one type of the many diagnoses of dementia. And as you see that the percentage, pardon me, is almost 80% of those receiving a diagnosis. And we see memory loss, communication challenges, impairment of judgment, that safety, the we see individuals with Alzheimer's disease are often showing signs and symptoms quite earlier than getting a diagnosis, sometimes even 7 years before actually seeing a doctor and getting a formal diagnosis. Vascular dementia is the second most common that is being diagnosed, and we can actually prevent a vascular dementia because this is from how we take care of ourselves. It's from a series of strokes, from heart attacks. It's about how we eat, our exercise, how we exercise our body, and how we exercise our brain. Lewy body dementia is where we are seeing closer to 15% of individuals that are receiving a diagnosis. Lewy body dementia often mimics a lot of symptoms that we see with individuals who are living with Parkinson's disease. Now, saying this, somebody who is living with Parkinson's disease does not necessarily mean that they are going to develop a Lewy body dementia, but we do see some similarities. One of the things that is really prominent with Lewy body dementia that we've noticed is that individuals are not able to tolerate medication as well as other people who are living with the various types of dementia, as well as individuals with Lewy body dementia. Their behaviors fluctuate quite rapidly. And frontal temporal dementia we see is at a 5%. We see that the memory is not the first thing that is starting to deteriorate, but whereas it's the behavior as individuals. So it's the I see it, I want it, I take it, it's mine. So why should we be concerned is because we are currently seeing that in Canada alone, we have over 600,000 individuals living with dementia. And actually, with the new landmark study, the one that just came out about a month ago, it is estimated that there are currently over 650,000 Canadians who are living with a dementia. 17,000 approximately are living in York Region alone. By the year 2050, our numbers are definitely going to increase. We are going to be well over 1 million Canadians that are going to be living with a diagnosis of a dementia. And those who are under 65 years of age are living with what is called young onset dementia. And we see that this number is increasing. And we have approximately 28,000 Canadians who are currently living with this diagnosis. And unfortunately, this 46% of Canadians are actually feeling that they would be embarrassed or ashamed if they had dementia. And it is our job as a community, as educators, to reduce this number so we can make sure that care partners and individuals who are living with a dementia do not feel the stigma associated with a diagnosis. So we see here that we have over 300,000 Canadians, sorry, pardon me, Ontarians who are living with a dementia. And unfortunately, individuals who are living with a dementia are at an increased risk of going missing. 6 out of 10 people will go missing. And unfortunately, if they are not found within a 24-hour period, that they are often found deceased. And when they are found in a very familiar place to them and often very close to home. These are just some signs to look for about why and how somebody may be going missing, behaviors that they may be displaying prior to having a missing incident. They may be showing signs of restlessness, showing signs of wanting to interact in an activity that they were once engaged in before. Because somebody is living with a diagnosis, whether you are living with Alzheimer's disease or any other type, or you're not, we all experience boredom. And just like everybody else, they may show that they have the tendency of moving things around or walking back and forth to the door. They could be looking for something from the past. Anxiety starts to increase and moving things around the house. It might become more repetitive and starting to see changes in behavior. Needing to make sure that a person has physical activity will help with reducing the chances of somebody going missing, as well as individuals often get confused with the time that they may be in. So how are we going to identify if somebody is walking down the street and they may be lost? We can look at how they are dressed. Are they dressed appropriately for the weather? Are they standing still for a long period of time? And are they just looking around? Are we looking at their body language as well as their facial expression? Are they showing more disorientation and fearful of the environment, as well as maybe people that may be around them? And if you can hear them, are they repeating the same questions over and over again? And are they actually staying within that same place? If you do feel that somebody may be lost or disoriented, then if you feel comfortable, please approach them. And these are some tips that you can use when you are going to approach somebody that appears to be lost. You want to approach very slowly from the front. Please do not sneak up to them from behind and put your hand and startle them. They are going to get startled, and we're not going to be able to provide them with that trusting, safe comfort so we can ensure that they do get home and connect with their families. We want to maintain that eye contact. This way, we can make sure that they realize that we're here to provide that support for them. You want to introduce yourself and say, "Hi, my name is Jamie. Is there any assistance that I may be giving you? Can I help you find your family?" Making sure that your tone, your body language is clear. You want to keep a very calm tone when you are speaking with them. Do not raise your voice, because when you raise your voice, it will give the person the impression that they may be in trouble. So if you can keep your voice at a very calmness, it will help build that trust with the individual. You want to try to keep your sentences as short and simple as possible, and allow time for a response, because it usually takes about 20 seconds for what we say to somebody who is living with a dementia to comprehend what it is that we're trying to say to them, and then the opportunity to respond. So don't jump in so quickly, and you may need to repeat yourself, and just repeat yourself exactly the same way so that person can grasp on to what it is that you are trying to say. When you are listening to that particular individual, make sure that you're looking at the whole person, not just the words, reading their verbal and their nonverbal cues as well. Be very patient and don't interrupt, because if you interrupt, you actually might stop that thought process and what they might need to say. You want to avoid making assumptions or correcting the person. It's about joining them where they are on their journey. It's not about necessarily bringing them into what our reality is, because their reality and what our reality is are going to be very different. If the person agrees, you can ask them for identification. They might even have the medical alert safe and safe and found bracelet. And I'm going to show you what that looks like in just a moment. Then if they don't have that, maybe you could even suggest calling 911, because if we're locating them and they may be lost, there's a good chance that their family has already reached out to the police to say that their family is missing from their home. So we want to make sure that we can connect them as quickly and safely as possible. So this is just an image to show you what the medical alert home bracelet looks like. It looks really much the same as a medical alert bracelet if somebody has diabetes or any other type of allergies. The difference with this is that it's blue and it's a quick identifier that somebody will be wearing if they are living with a dementia. And on the back, it has a phone number to contact. Sometimes people may be registered with the Project Lifesaver or the identification card that they may have that they can actually give to you, which will highlight their emergency contact, which you also can actually call to make sure that they return home safely. Through all of our 26 societies across Ontario, all of our societies are here to provide our communities with supports and services, with education, with information for care partners as well as those that are living with a diagnosis. So if you are looking for any type of information for yourself as a care partner or for somebody else, please feel free to reach out to any of our societies. And if you're not sure which society you can connect to, you can go to our website and you can just look and see, or you can give us a call and we'll help connect you. If you'd like more information about the Finding Your Way program, please take time and go on to this website. It is a great program with great strategies that I truly believe will help keeping all of our community members, our care partners, and those living with a diagnosis independent and safe. We also have another phenomenal program that is the Dementia Friendly Communities, which is how we can incorporate our community businesses and how you can become dementia friendly communities and learning about how you can provide a friendly environment in your business for care partners and those living with a diagnosis. Here is the website. If you are interested as well on your staff being trained, please feel free to get in touch with me. And here is my contact information. So you are more than welcome to get in touch with me, and I'd be more than happy to share any kind of information. Okay, so now, without further ado, I would like to introduce Dr. Orange. And highlighting Dr. Orange's accomplishments throughout his years. So Dr. Orange is a professor and a research professor in the School of Communication, Sciences, and Disorders at Western University in London, Ontario. Also as a research associate with the Canadian Centre for Activities and Aging at Western University. His peer-reviewed publications and funded research addresses language and cognitive communication disorders of adults and older adults. His research has special emphasis on, on discourse, conversations, and communication of individuals with various types of dementia. He's currently participating in collaborative interdisciplinary research on several national and international funded studies. Several of Dr. Orange's current funded research studies have included investigations comparing and contrasting the linguistic, cognitive, and neuroimaging profiles of persons living with Alzheimer's disease, several types of frontal temporal lobe dementia, vascular cognitive impairment, and Parkinson's disease, especially for those with hearing, vision, and both hearing and vision impairments. It is my pleasure to introduce Dr. Orange.
Great. Thank you, Jamie, for a wonderful introduction. That's kind of you to do that. And also thank you for providing some valuable information about Finding Your Way program. It's interesting to see how well it's developed since I first learned about a wandering registry back in the early 90s when I was doing my postdoc at McMaster University. So thank you for the update on that program. It sounds absolutely very useful. So welcome everyone to the session. As I recall, Jamie and I were talking about this earlier. This is, I think, my fourth talk for the Alzheimer's Society of York Region. So maybe by the fourth time I'll get it right. They keep inviting me back because I guess I'm not getting it right. Anyway, I hope that you find the information valuable today. There's a question and answer session at the end. Although if you want to have a question that's burning, you need to have it answered right away, then just pop it into the Q&A box and Jamie's going to be monitoring that. As I responded on the chat section, I'm also going to make my PowerPoint slides available after the session today. It won't include the videos that I have because some copyright issues and research issues and ethics components, but I'll make all those slides available. I will warn you, I have 91 slides. So I have a long set of slides that I need to get through, some of which I'm just going to skip over quickly. You can read those later for your information. And I also talk very quickly, so I hope I at least get all the information that you find useful today. So let me share the screen, get my slides up and running here, and see if I can get them And please let me know if you can't see my slides or I'm not talking clearly enough. So let me. How are we doing? Nope, it's not the one. Can you? I don't think you can see those. Hang on a sec. Sorry.
Yep, I can see your screen.
Okay, I'm. Oh, are they coming up? That's right. It worked when I first started. I'm gonna stop the share just for a second. Let me try this again. Here we go. Okay, there, Jamie, they're up. You can see.
Yes, they are. Yeah,
Okay,
perfect.
great. So background information. As with any researcher, I need to um, show you my disclosures, which indicate that I don't have any financial interest or arrangement or affiliation with the Alzheimer's Society of York Region. I don't have any affiliations with pharmaceutical, medical device, or communications organizations, and I promise that I'm going to make my presentation balanced and reflect the current scientific literature. I was also, as part of my disclosure, I need to indicate where I'm getting my research funding from. And currently, I hold a social sciences and humanities research grant, a partnership development grant on a database called Herald and social participation for people living with dementia. I'm also part of the Ontario Brain Institute, Ontario Neurodegenerative Research Institute, doing some analysis of various types of people living with various types of dementia, the Canadian Consortium for Neurodegeneration and Aging, as well as funding that comes from Employment Skills Development Canada on a program called BEPIC that I'll talk about a little later. And finally, a project that a colleague of mine, Dr. Angela Roberts here at Western, is doing in collaboration with colleagues in the United States for the National Institute of Health on superagers. It's for those people over the age of 80 who show real strong cognitive performance that mirrors those in their 50s. And so I would urge those of you in the audience who are over 80 and would like to learn more about that, you can get in touch with me and or just Google superager study at Western and you can enroll in that study. So part of what I want to do today is to provide background information on some terms that help make you a better problem solver. And for those of you who attended my previous sessions, I always start off with this background foundational information. So hopefully this will solidify some of the previous material you've heard from me. I'm a speech language pathology researcher, and so I need to make distinctions for you about the differences among these four terms: speech, language, communication, and cognition. So when I'm using the word speech, that sometimes people will use in terms of expressive language, I use it in a very narrow way, much like all my colleagues in the research and clinical fields, where speech production, that is the making of the sounds, and speech perception, hearing of the sounds, really relates to how we communicate with our vocal system. That includes our lips, our tongue, our jaw for articulation, our nasal cavity or oral cavity in the upper part of our pharynx called resonance, how we use our lungs for phonation, how we use our voice box for phonation, and how we use our lungs for respiration. So these four levels of articulation, resonance, phonation, and respiration really all combine together to allow us to make all the 45 sounds of the English sound system. Speech production is contrasted with language, and language really is a set of symbols that are arbitrarily developed, and they have a variety of components or rules that govern how we use these meaningful units that represent ideas. So in English, for example, we have a rule system about how we put sounds together in certain combinations. Not the making of the sounds, that's speech production, but for example, rules that guide us to say that in the English language, there are no words that end with the sound. We have lots of words that end when we print or write the letter H, but we never end a word with the sound. We never have words that begin with the sound none. So these rule-based systems govern how we put the sounds together to form these meaningful units. Grammar and syntax are two other rule-based systems about the ways in which words agree with one another in a sentence. So for example, in this slide, the boy ran to the store is bad grammar. It's incorrect use of the past tense, run. Syntax refers to the order of these meaningful units in sentences that we speak or we write or we sign. In this example, to store, the boy the ran, rejumbled is the boy ran to the store. So phonology, grammar, and syntax form what we call the form elements of language. These rules that toddlers and young children learn by the time they're 5 or 6 and can order words together in special ways that ask a question or make a statement and organize the positions of sounds and words. The fourth rule-based system that has direct relevance for us today is the term called semantics, and that really refers to our mental dictionary, or sometimes referred to as our semantic knowledge or semantic memory. And this semantic system represents those words that we know and have meaning attached to them, essentially this mental dictionary. And so if you think about how you define the word car as a vehicle made of metal and plastic, it has an engine in it, runs on gasoline, sometimes it's run by batteries, it has glass in it, and it can hold anywhere from 1 to 5 or 6 people and moves. It's a method of transportation. So these rule-based systems of phonology, grammar, syntax, and semantics all combine to help us guide the symbols that we use in language. This last term on the page here, or on the slide, is called pragmatics, and that is how we use this language in various contexts that often then bleeds over or relates to the next term, which I'm going to talk about, which the third term, which is communication. And communication really has two components to it. It's the exchange of ideas between two or more entities, you and your mind, or you and somebody else. And as the diagram illustrates, it is the keystone that holds up the arch of human interaction. Without communication, we really have no way or opportunities to interact with anyone. So interactions with other people is based on communication, where we establish, maintain, and change relationships to exchange these ideas. Communication has multiple forms, whether it's in a formal context like this, or the conversations you have with family members, or the conversations you have with relatives or neighbors. And these contexts, like the previous term pragmatics, define how we use the vocabulary, the grammar, the syntax, and how we actually say words and use nonverbal elements of communication. We think of speech, language, hearing, and the fourth term I'm going to talk about, cognition, really as this bidirectional element where there is somebody who is writing or speaking or using nonverbal elements of facial expression, body postures, gestures, and then our partner, our other interactant, who is understanding what we're saying, that is auditory comprehension. They're reading what we've written or signed or gestured or typed, and they're also picking up some of the other elements of the context of the smell, the taste, the touch, that gives us a richer element of the context in which we're communicating. So that's speech, language, and communication. The fourth term that I'd like you to come away with and understand is this concept of cognition, which really reflects all of the mental operations and activities that go along with gathering information, transforming it, storing it, decoding it, and calling it back up again. And so this term cognition refers to all those mental activities, including our memory systems and processes, our attention systems and processes, our judgments, our reasoning, our insightfulness, and other ways in which we gather information to create knowledge. And speech, language, communication, and cognition are all intimately linked, but there are these important distinctions among them, and this and understanding those distinctions will help you understand why our friends or relatives who are living with dementia manifest in certain ways and give these certain symptoms. So this diagram is an illustration of the human memory system. And I don't expect you to reproduce this or understand all of it, because I'm going to spend most of my time on this side, which would be the left side of the screen, whereby information that we sense, we see it, we hear it, we feel it, we taste it, we touch it, etc., gets processed, and it gets put into this part of our memory system called the primary active or working memory system. And if we decide that this is an important piece of information or series of pieces of information, we move them down into long-term memory. And if we think this is information that we want to be able to call up and declare it again later, we put it into either a concept or semantic memory or semantic knowledge, that is the definitions of words, and that's a concept-based memory. Or if we want to store this piece of information as an event or time-based, that is remembering your birth date, or remembering anniversaries, or remembering important political or historical events, that becomes an event-based memory. And then, of course, we also have within our declarative memory this word or lexical memory. That is, all of those memories and rules that I talked about earlier around how sounds get put together, the order in which words appear, and how words agree with one another to identify plurals, adding an S or the sound Z, or adding ED for past tense. So this declarative memory, which is part of our long-term memory system, is preferentially ravaged among people with dementia. And in varying types of dementia, various types of these memory systems are differentially affected. So these next series of slides that I'm going to just move over quickly have background information about how we define a short-term memory or working memory or episodic memory. So I leave that to you to review at your leisure because I want to move forward with other information related to background on communication specifically. So I've got this slide that gives you the background information. And of course, Jamie was very good to identify what dementia was, and this is the definition we use in research, that really dementia is a syndrome. That is, it's a collection of different diseases and disorders that interferes with our ability to do things in everyday lives. And it's not explained by delirium or major psychiatric disorders, and that there is a cognitive impairment, that is an impairment in memory systems, processes, attention systems and processes, judgments, reasoning, and that not only can we measure that with various tests and assessment protocols, but also there's a history from a client or a knowledgeable informant about that husband or wife or grandma or grandpa or your bubby or your nona are having some difficulty. And so others will identify that there's something not quite right with mom or dad or bubby's memory systems or judgments or reasoning. And part of this definition requires that you have to have in 5A an impaired ability to acquire and remember new information. That's essentially your memory. You have to have impaired reasoning or judgment skills, which I alluded to earlier. You have difficulties with visual spatial, that is right from left, foreground from background. You can't quite see how one object relates to one another. I've highlighted 5D here because it's really the key for us today, which is that language and communication problems, all of those elements that I've talked about earlier, speaking and reading and writing and gesturing, are impaired to some degree. And finally, there are changes in someone's personality. So for this definition of all types of dementia, generically, whether it's Alzheimer's type dementia or vascular dementia or Lewy body spectrum disorder dementia or frontal temporal dementia that Jamie illustrated, you have to have two of these 5 areas impaired. More recently, the Diagnostic and Statistical Manual decided, and the people who support that, we're going to change the word dementia to a major or minor neurocognitive disorder. Regardless of what the label is, dementia still remains a syndrome of which you have to have a certain type of profile of problems, including complex attention, executive function, which means judgments, reasoning, insightfulness, and part of your working memory, learning and memory difficulties. I can't hold on to information for a short period of time or put it back into my long-term memory, or for that matter, store it properly or even retrieve it. And of course, language remains a key element of the definition of dementia. And the last element here I want to point out is this social cognition, which is a new component to the definition of dementia. And that refers to the challenges that people have in using their cognitive skills in everyday functional ways. That is, someone might be swearing inappropriately or saying things that are unkind and not recognizing that the social contexts require you to adjust your communication and your behavior, which for those of you who are listening to me closely would relate to this concept of pragmatics, which we use in speech language pathology to refer to the social forces that guide how we say things. So it's a nice element within the new DSM-5 to see the social cognitions added. Part of today's session is really to reinforce person-centered communication for people who are living with dementia. And I, as any researcher would often do, you want to at least come from the main themes of your presentation from a theoretical perspective. And I'm going to talk a little bit briefly about this theory called the communication accommodation theory. And it was first described in the early 1980s and 1990s that really describes how people, interactants in these slides, bring pieces of information to a communication interaction that will either hinder it or make it successful. And the communication accommodation theory says that when speakers and listeners, or readers and writers, or viewers and signers come together, their interactions with their interactant is based on past interpersonal and intergroup experiences with similar type of people or not. And as a result of these previous experiences with that individual or similar individuals or in their group experiences, speakers and writers and signers will adjust their communication based on what their partner is giving them in terms of nonverbal or feedback, but also their past experiences. So we accommodate to people's perceived needs based on our own experiences. So communication accommodation theory says that each speaker or writer or signer evaluates and makes attributes about the interaction, the context, and who the person is. And that means it's on a person by person basis. And that any feedback that comes from the listener or the reader or the person who is picking up on the signs will force the expressor, the writer, the speaker, or the signer to change and to accommodate to the other person's needs based on your previous history of this person or similar people or your experiences. And so communication accommodation theory really brings this down to a person level adjustment in your communication. However, when we put it in the context of, that is communication accommodation theory, and aging, there is some adjustments that people will often make that create predicaments for older adults. And this is a model that was first described by my colleagues way back in the mid-1980s that guided us to develop another model. But the communication predicament of elderly people or older adults says that when you encounter an older person, you recognize old age cues, you invoke some stereotyped expectations, you modify your speech or your expressive language, and that in turn creates all sorts of constraints on the far side. And so in the next series of slides, I'm going to break this down a little bit more because it sets the foundation for how I want you to come away from today's session, which is thinking about person-centered communication. So as I indicated, when you, in the communication predicament model, when you encounter an older person, you identify physical signs: white hair, glasses, stooped posture, maybe the type of clothing that they're wearing or the aids that they're using, glasses, hearing aids, walkers, canes, etc., or the context in which you find them. It could be at the malls, it could be at volunteer retirement homes or community centers. And it may be the way in which the older adult is communicating, or for that matter, their date of birth, that you know that someone who comes to see you and has the date of birth of 1941 is well over 80. And or their names might be an indication, even before you see the person, that they might be old. So we know that there are certain cohort names like Mildred or Charles or Muriel or Elizabeth that might invoke an older type of person. And of course, those names change over the time course, because probably in 70 years from now, Tiffany and Amber are going to be the older names for older adults. As a result of identifying these old age cues, you invoke some stereotyped expectations. And this is not communication accommodation theory at its best. As a matter of fact, it's called over accommodated communication, that because you have identified this person as old, you invoke these negative stereotyped expectations of incompetence, dependency, cognitive decline, they have a hearing problem, and you focus only on the negative stereotypes. So that's part of the outcome of interacting with these older adults. And as a consequence, you then modify your speech production and language behaviors. And that's called, as I indicated, over-accommodated communication, or sometimes referred to as elder speak, secondary baby talk, or patronizing communication. And it really is, it's the paradox of a communication predicament of older adults. That is, they require some accommodation because they have some cognitive impairment or hearing impairment, but you don't have to automatically make that assumption. And when you base stereotypes on incompetence and dependency, you shape the behaviors of the older adults, and then they become self-fulfilling, learned helplessness about, you're talking to me like a child. And so, as indicated, this over-accommodated communication, often referred to as elder speak, patronizing talk, or secondary behavior, is well described in the literature way back in the early 80s. And it's a high, extreme form of patronizing communication that includes these parameters, and I'm going to show you a few more. But the data that support elder speak or secondary baby talk has been found in a number of different contexts, real world data gathering between long-term care residents and staffing, family members, neighbors, and relatives. I participated in many of these early studies during my postdoctoral work at McMaster University, and that what we found was not only in the real interactions, but even when we crafted communication in written form that had no sounds to it and no verbal, people heard and saw these demeaning behaviors. Interestingly enough, in some of the earlier work by Linda Corporeal, she found that staff who had more negative attitudes about the abilities of older adults actually used more elder speak. That is, if you thought older adults really were incompetent, then you were more likely to use more elder speak. Some of the work by Susan Kemper at the University of Kansas, Alan Ryan at McMaster University, among others, have identified parameters of this elder speak or secondary baby talk. And increasing your loudness, as you'll come to see when I get to the hearing aid section on strategies, is not often helpful. You exaggerate your intonation, use a higher pitch, which in many instances for older adults is actually worse. It doesn't help them. You often simplify syntax or simplify content, and in some ways that can be helpful, especially some of the work that Susan Kemper was, and as Jamie alluded to earlier. But sometimes simplifying context and simplifying content and syntax doesn't always work. When you use terms of endearment like pet names or nicknames, or you make presumptions that you're close to these people, that creates an imbalance. And of course, using sometimes first name is not appropriate. This next slide, which I'm sure you can't see all that well on the screen because the print is very small, but you'll be able to review it when I send you these slides, describes the elements of patronizing communication in vocabulary, in the grammar, the forms of address, how well you manage the topic. That is, you talk a lot, you don't let them intervene, because there's a presumption that all older people are loquacious. They go on and on and on, so I better not let them talk. I'll never get my work done. You have parameters around the voice quality. We call it phonation, the way in which you look at or don't look at, how close you are to the person, frowns and gestures, etc. So these are parameters that really are well defined in the literature that outline elder speak. There are also elements of that Alison Ray has written about of the use of the over-inclusive term we. I've given you examples that Alison has here, and then we'll all have a cup of tea as the staff or the or family members are talking to the older adult. Well, it's not the we, it's you. And so the overuse of the we creates this barrier between and doesn't really provide person-centered levels of communication. And you'll see that in a couple of video examples I'll show a little later. So what are the consequences of this? Again, well described in the literature that there are negative stereotypes and self-perceptions by the older adults. You're talking to me like a child, then I'm going to act like a child. The older adults then end up with lower self-esteem because you're demeaning and demoralizing in your talk. And we know the parameters from multiple studies that more complex sentences, even short sentences that have vocabulary that's unfamiliar, a high pitch and slow speaking rate, are not helpful. What is helpful, as Jamie pointed out, repeating, but also just as importantly, paraphrasing. That is, using redundant words, synonyms that might be a little easier to understand. So sometimes repeating exactly doesn't always work. Sometimes you need to adjust and you change the vocabulary just so that you give maybe a simpler term. And that is simple sentences. And what I mean by that, by grammar, syntax, and semantics. It is in grammar, a subject, verb, object in the present tense, not future tense, not past tense. Syntax, you'll find out that negatives are not really understood all that well. And of course, using vocabulary that's appropriate for the individual. So part of my earlier work in my research career a long, long time ago was to develop the yin to the yang model of communication predicament. And so we developed the communication enhancement model that bears similarities to the predicament model. However, that when you recognize old age cues, you then modify your communication on an individual or personalized basis. That is, you need to get to know who your interactant is by doing an individual assessment or gathering information from your colleagues in psychology or nursing or occupational therapy or physiotherapy or audiology, et cetera. And once you find out, and of course our medical colleagues in geriatric medicine or geriatric psychiatry and neurology, once you find out you've gathered information, then you can be a much more effective communicator, empower yourself, as well as your older adult interactant who will then have a higher well-being and maximize communication. They will want to interact with you, and that's been the basis of much of the research that I and several of my colleagues have followed in over the past decades in this communication enhancement model. Now, I've given you this diagram. Again, I don't expect you to see it all that well, but you'll be able to review it when I give you the slides. And this is an updated of our model by colleagues Deanne O'Rourke at the University of Manitoba. And it's in the context of a communication enhancement model, but person-centered communication, which I'm going to go into shortly. So you can review that. It has similar tenets or themes to our model. So in this context of what I'm hoping you'll come away with today is this notion that our friends or relatives or those whom we're providing care for really indeed have a self and a personhood, even though cognition sometimes may have robbed them of that. We need to be thinking of what is personhood and what is self. And really, it's a standing or status that's bestowed upon one another, and it implies some recognition, respect, and trust. And typically, a biomedical model doesn't really focus in on self and personhood. And so we need to be reminding ourselves in our interactions with our loved ones who are living with dementia or those whom we're providing care for that there really is a self and a person in there. And that self and personhood are related to the concepts of interdependence and interconnectedness, and that we can think about various facilitators that are going to enhance person-centered communication, that is personhood affirming communication. Stephen Sabat had talked about elements that people who are living with dementia show that reflect it even in the middle or moderate or late or severe clinical stages of dementia, that a person living with dementia can use the words like I, me, my, and mine that reflect that there's a personal identity. They also will describe themselves as some characteristics or qualities that, I'm a very patient person. I was a talkative person. I was a quiet person. I was a great seamstress. I was a wonderful leader in my church or my synagogue or my mosque or my temple. And thirdly, these public persona profiles. I was a Girl Scout leader. I also was the treasurer of my again church or synagogue. And so these three parameters are often observed even in people with late or severe stage clinical stage dementia, which then reaffirms that there is a person in there. We just need to be able to find the right ramps or look through the right window. And part of today's session is to get you to think about person-centered care, but specifically in the context of person-centered communication care. So hopefully this reminds you that person-centered care, which comes out of the literature in nursing as well as in occupational therapy and sociology, means that individuals' values and preferences are elicited. It guides all of our healthcare. And of course, many of you who have been in the healthcare system may have come across wonderful people who are person-centered as well as those who are not so person-centered. And so we want to be sure that we optimize person-centered care in the larger context of healthcare. And then we put in this added element of person-centered communication care, that communication values and respects the person. It promotes an individualized approach, much like our communication enhancement model, and that you understand the person's perspective. That is, you can take from your view and go into the other person's view and say, gee, how would I like to be addressed? How would I like to be shown or guided through this? And so this person-centered communication within the context of person-centered care gets added and focused even more within the context of people who are living with dementia. So it becomes person-centered dementia communication. And I've given you some examples of relevant literature that you can see later on. So what I like to do now is to show you a video, some of you may have seen this before, about an interaction between a standardized patient and a nurse, standardized nurse. And these were videos that were taken shortly after I left my postdoc at McMaster University, but I think it's very relevant for today's session about how you have person-centered communication and also a context of when you don't have it. So we have the communication predicament, and then we have communication enhancement. So I'm going to show this video to you because I think it illustrates, the basic theme that I want you to come away with today about person-centered communication. Okay.
Well, I don't like a person that just comes in and says, take your blood pressure, this and that, and not be like try and talk or be sociable or, there is some like that that just does their business. Goodbye, I'm gone. Well, it's important to me because you feel you're just an object to them, right?
Hello, Mrs. Vickers. How are you today?
Not too bad. I've been kind of sick for a while, but not too bad now.
I'm really in a rush today. I'm having a busy day. I don't see any sheets here. Are you sure that it's in here?
You want me to look for it?
Oh no, here, I found it. Okay. So what do we need to do? We need to check your blood pressure today. I need to check to see how your dialysis is working. Okay, I'll just put that down for now. Oh. Your face looks a little bit, or your skin looks a little bit dry today.
It is.
Yeah, have you not been using your lotion on your skin? You're supposed to be using it twice a day. All right, can you just move your arm, please? Thank you. Thanks. Okay, here we go. It's gonna feel tight. Okay, just hold still. Okay, your blood pressure is really up today. It's running about 200 over 110. Have you been eating a lot of salt lately? If you have a lot of salt in your diet, that'll make
But I
your blood
am now
pressure.
because they told me so when it was down so low.
So you have been eating too much salt then. Well, maybe you should think about cutting down. If you use too much salt, that really will make your blood pressure go up. And you really shouldn't be doing that. But you're not following your diet very well, I don't think, okay? Okay, Mrs. Vickers, how is your dialysis treatment going? Can you tell me about that?
Yeah, if they want me to lose weight, they put 2 4s and 2 1s on it.
Is that right?
But if my weight is low, they just put 3 1s and 1 4.
Right.
That's how that works.
Okay, but I don't mean that. I just mean is it managing to clear your weight out properly, and that's all right. Do it different ways. Okay, well that's good. So you're pleased with that. There's no problems there.
No problem.
Okay, any other problems at all?
Not really.
No.
I don't like you said my high blood pressure's up.
Right. Okay, Mrs. Vickers, if there's nothing else, I have to run now. Okay, we'll see you tomorrow. Bye-bye now.
Bye.
It's important for me to have respect, which also affects my health and my outlook on life, my mental outlook on life. And like I said, feel like somebody.
Good morning, Mrs. Vickers. How are you today?
Oh, not too bad.
I haven't seen you in a couple of weeks. I've been away on holiday. Yeah, you're looking well. Yeah. Do you mind if I sit down? We can talk.
Go ahead. Help yourself.
Okay. So what have you been doing lately? What have you been doing to
What have I been doing? I went fishing a couple of weekends.
Did you really?
Christie's Conservation, 50 Point Road. Got nothing but little things, but we went fishing and I go bowling and things like that. I crochet a lot.
Feeling more like your old self.
Not too bad right now. Pretty good.
Good. Okay. So how's your blood pressure been lately?
Well, it's going up, as I said, but it was down. And this last month, it went so low, got scared. Then they told me to take salt. Now.
Right. Okay, well, maybe we better double check it to make sure that it hasn't rebounded and gotten too high again. So could you lift your arm just a little, please? I'll just pull this up a tiny bit more, and I'm going to pump it up a little bit high today just to double check to make sure that it hasn't gone up. Okay. Your eyes look nice and bright and clear, so that's usually a good sign to me. Okay. Now your blood pressure is a little bit high right now. It's about 200 over 110. Now I'll have to.
90 is normal.
Yeah, I think about your salt diet. Maybe we should look at cutting your salt back a little bit.
I'll drop it out.
And I want to give Dr. Carlisle a call. Yeah, is he on holiday right now?
Yeah.
Okay, well maybe
you can get Chris or Carol.
Oh, his nurses are.
They'll take his place. Chris is back now.
Okay. Anyway, I'm having a busy day today. You know what nurses are like. We're always rushing.
I know.
So I'll be back tomorrow. Is 10 o'clock all right with you if I return?
That'll be fine. 10? But I got one thing to say to you. Safe driving.
Oh, well, thanks.
Would
you like a drink of water before I go? Are you thirsty?
Yeah. Derek got rear-ended last week.
Oh, no. Well, I know a few of the nurses
he's got a new car coming in.
Oh, well, that's one way to get air conditioning, I guess, isn't it? All right. Okay, are you comfortable? You got everything you need?
Fine.
All right. Well, look, you take care, and I'll see you again tomorrow.
Okay.
Okay. Bye
God
bye.
bless.
I'll just check your calendar here. Okay.
It's up on the top one.
Oh, it's here. Okay. Great. Thanks. Bye now.
Okay, bye.
7 seconds. It's 7 seconds longer in the second conversation, which is more communication enhancement, right? So for 7 seconds, can you afford to have an interaction where you ask Mrs. Vickers for permission to sit on her bed, you're asking her for her input, you're being respectful, versus in the first interaction where your agenda is driving everything. I'm sorry, I'm too late. I'm looking at my watch. Nurses are so busy. You shouldn't be doing that. Accusatory tone, language-wise as well as speech-wise. So I think that video captures the essence of really the communication predicament of not being very good, and then person-centered communication by using the communication enhancement model. So anyway, I love showing that. This excerpt comes from a book by Richard Taylor, who is a physician who also has dementia, but I pulled out this small snippet and highlighted in red, where he focuses in on, too much time is spent questioning each other, asking this information, but really what I need is to feel like I am being heard. So that for me reinforces the notion of we often have to then check our agenda at the door sometimes, or just put it in a parking lot for a moment while we try and answer all the questions that the person living with dementia may have and show person-centered communication. This example comes from an excerpt from Judith Miller, who wrote to Globe and Mail, saying that the death of conversation is awful for care providers and spouses. And so she's just reminding us to reach out to spouses or care providers, like many of you are here today, because the conversations that care providers are having with their relatives with dementia is problematic. And so all friends and relatives in that social network and family network need to be redoubling their efforts to make sure that a conversation, not only with the person living with dementia, but also her, his, or their care providers, it becomes part of our focus. I want to spend the rest of my time, although I've only got I think Jamie can remind me, we're supposed to go till 2:15, maybe 2:30?
Till about 3 o'clock-ish.
Oh,
So
okay.
you still have lots of time.
Okay, great. I'm only a third of the way through the slides, but I'll try and move along expeditiously here. So I'm channeling the work by the late Tom Kitwood from the UK, who wrote extensively about positive care interactions and personhood. And in particular, he had developed 24, 25 parameters of what he called person positive care interactions. And my colleagues, Alan Ryan, and Marie Savundarnayagam, among others, have focused in on some elements of Kitwood's strategies that include the terms facilitation, negotiation, recognition, and validation. These are four we've pulled out from the larger category that reflect, I think, person-centered communication. And I'm going to go through each one of these in the next series of slides with some illustrative examples. So facilitation within the context of person-centered communication refers to the ways in which we build together. We involve our partners' initiatives and abilities in a shared task. We try to do what otherwise the person would not be able to do. We provide missing elements or information. We help them get started to amplify them and to help the person fill in the missing information. And I'm going to describe the strategies to how to do that. And we help to enable the person to sustain his interactions, to keep the interactions from getting lost because of their memory or other cognitive issues. So facilitation means that we need to be ready to initiate or to respond to the person, which means then we need to see them, be in touch with them. We're neither rushing too soon or holding back. You've got to find, as I indicated here, the sweet spot of when we come in, and that we're going to, borrowing the literature from my colleagues in aphasia, which is a stroke-based focused language disorder, we're going to try and enable the use of their remaining abilities. That is, we're going to try and build these ramps to help them retrieve the word or provide a context that makes communication meaningful, filling in gaps. And it might mean that we're going to elaborate on the topic, or we're going to provide very specific requests or specific information, which I'll get to shortly. And it doesn't include instances where we say, do you remember or don't you remember? Because that's not really facilitating. That's focusing in on their inabilities. We already know that they can't remember. So why would we ask them, do you remember, when they can't remember? So part of facilitation is not to focus in the negative. So here are some examples of facilitation using language strategies that come from some of the work that Tom has written about in Ellen Ryan and I, and along with Marie and I, Subun and I, Gam. So, for example, we visited Melanie in her hometown of Winnipeg in January. So there's lots of redundancy within that. Hometown, Winnipeg, January, got to be cold, even in this context of global warming. And in the second example, Paula, is that the CN tower that is pointing to the particular picture or the actual item, and giving, in this case, an alerting device that is Paula, calling the person's name. And then when we ask questions, as was illustrated in Jamie's earlier talk, what was your favorite part about Hannah's wedding? Was it the wedding vows or the music? And I purposely use this one because when we ask questions, sometimes we want to avoid WH questions, but we can follow up quickly with options. No more than 2 options, because of the working memory or short-term memory problems our relative or friend or resident has with their memory, their working memory. So you can't put too much in the basket, as it were, the bucket. So you give them 2 options. We can ask, again, why Roger's looking in the utensil drawer. We could just say, why are you looking there? Are you looking specifically for the spoons or the forks or the, in this case, 2 options. But if we just said, what are you looking for, Roger, in the utensil drawer? Utensil is a low frequency of occurrence word. You could call it the cutlery drawer, but you're going to give some options. Is it the spoons or is it the forks that Roger's looking for? So you're focusing in on maybe what he's searching for. And of course, in these last 2, the person living with dementia said, I thought that was at Thanksgiving. And the care provider says, yes, it was a delicious meal at Thanksgiving in October. So giving the time frame for it, and delicious meal, and Thanksgiving, all of those within the context of confirming and facilitating that person living with dementia's understanding about that was delicious, that I thought that was delicious. They couldn't even say the word meal, but said that instead, which is a demonstrative pronoun. And of course, in the final example, the person living with dementia asks an orientation sort of type question, why were we there? And we were there, using part of what the person said, we were visiting your sister Patricia. So giving specific information. We could have just said, we were there visiting. Well, visiting who? Your sister. Well, which one? Was it Patricia? Was it Mary? Was it Leslie? So giving the specific information facilitates that interaction. The second of these 2 strategies is called negotiation. And of course, based on the definition, we're consulting our partner's preferences or choices and their desires or needs. And so here's some examples. And it gets back to the earlier issue around asking questions and giving forced choices. Do you want to switch to the next picture now? In this case, it's a yes/no question. Or in the second one, do you want to watch the news on TV or do you want to listen to it on the radio? There's your choice. So it's yes/no questions or forced choice questions versus what do you want to do now, which is too open-ended, too non-specific. In this particular case, you can give a bit of a background information and then give the options. So our friends, the Lammers, are coming over to visit us. We have cheese, fruit, crackers, and wine. And I'm just going to point out something a little technical here. I could have said, we will have cheese, fruit, crackers, and wine, but I don't want to do that. I want to keep it in what we call SAD sentences. Simple, active, declarative, not emotionally sad sentences, but it's an acronym we use in our field of speech language pathology, that it's in the present tense. Our friends, the Lammers, are coming over to visit us, not our friends, the Lammers, will be coming over to visit us. No, it's always in the active present tense. And then the question is, when shall we put out the snacks and wine? Right now or in 30 minutes? You can even make this tighter and say, when shall we put out the snacks? Of course, you've already said cheese, fruit, crackers, and wine, so you're being redundant. So all of this is negotiation to build up to the person being able to say, not right now, or yes, we need to do right now because we're having red wine and we need to decant it. Anyway, the third element of this person-centered communication for recognition is, for Kitwood, is recognition. And there, in this particular context, we acknowledge the person, calling him or her or them by their name. We affirm their person by including part of their life, as I indicated to you, their beliefs, their qualities, the roles that they had. And so the examples here are, hi, Mr. DeLonghi, and it may be, for those of you in a long-term care facility, you're referring to them as by their full title and name. How are you feeling today? So I've got his attention. Hi, Mr. DeLonghi, and how are you feeling today? And then the same holds true here. How many grandchildren do you have, Mrs. McLeod? And how is your talkative husband, Hugo, doing? So all of these phrasings and structures are designed to alert the partner, our interactant, who they are and specifically what it is we're asking for them, right? I could have said, how many grandchildren do you have? And because our person living with dementia is older, may have a hearing problem, may have attention problems, may not be focusing in on you, by giving the name, you then alert them. And then, as Jamie pointed out, you have a period of time you want to give them to respond. Okay. Recognition also includes some of these other examples, giving fair amount of background information that helps you reaffirm what you're talking about. And this is a statement that your youngest daughter, Ursula, the nephrologist or kidney specialist, visits you usually on the weekends. And that just helps recognize the context in which I'm communicating, right? And of course, the same holds true for this other example here that I won't go over. But it does the same thing and provides recognition for the person who's living with dementia. The fourth strategy is called validation. And validation is important because really what it does, it acknowledges the reality of the person's emotions and feelings, and you respond to her, his, or them. And Jamie mentioned this at the beginning. And so validation permits you and requires you, for the most part, to be in that person's reality. Because we know that reality orientation does not work. We can say that, to everyone here time and time again, today is Wednesday, the 20th of March, 2024, and we're in this webinar session sponsored by the Alzheimer's Society of York region. But is that important for the validation of the person's status in the communication? And so we want to be able to do is appreciate, respond to whatever the person is expressing. And you use empathy, that is, take their perspective and gain a sense of what they're experiencing. And so here in these examples, you want to understand their emotions and your emotions and acknowledge that. So essentially, you're validating what they're feeling, even though, for example, those who may have Lewy body spectrum disorder, that their visual hallucination, in addition to their auditory hallucination, is real to them. But, I don't see that alligator in the corner, but I know it's there for you, and I'm sure it's scary for you. I'm validating that, but I don't see that. Or I know you hear that person talking to you. There's no one here, but you don't need to be frightened about them. And you validate that. So these examples, reaffirm that the person living with dementia has these perceptions, even though we may not see them, we not understand them completely, but we're validating them. And that will, in some instances, especially for those who have frontotemporal lobar degeneration, behavioral variant or frontal variant, they get very excited, highly emotional, can be very aggressive. You don't want to get into a verbal Donnybrook with them and confront them about, no, that's not happening. You say, that may be a reality for you. I don't understand. I don't see that, but I'll acknowledge that you understand that. And so that's part of the validation, and using your language and vocabulary in present tense to be able to acknowledge that and help diffuse any anxieties or frustrations that our partner may have. So I also want to illustrate in this next video, in which there is on the right-hand side of your screen, the transcript of what this husband and wife are saying in their own home at the end of a meal, where MD stands for the person with middle stage dementia and SP stands for the spouse. I want you to listen to this interaction and stay attuned to, unfortunately, how the spouse is not listening to her husband, because her husband answers every question. So I'll unpack that as you listen to this. I'll unpack this after you listen to this, okay?
Wow. That's six, yeah.
What's that called that you're looking at? What is that called that you're looking at?
What? You want me to?
What is it? What is it?
What?
What is this?
Hmm?
What's this?
Well, sure.
What is it?
What do you mean? What do you think it is?
What is it called? If I sent you upstairs for this,
The light.
a light.
Man, got that.
I'll take your plate and you can have your cake.
All right, so this is an interaction from some of my research data and the type of communication breakdown that I've studied, along with others as well who have looked at this. And in this particular case, we've described the spouse as not being an active listener, because when she's posed questions, the husband's answered the questions, but it's not in her mind the answer that she's looking for, because she already has an agenda. So in this case, at the beginning of the interaction, the husband says, well, not 6 yet, as he looks at his watch. And so the spouse then says, and there's no one else in the house, there's just the two of them. I've been in earlier in the day and video recorded them during their lunch meal, and then I've come back in the evening. This is their evening meal, so no one's in the house. They're just acting as spontaneously as they normally would. And she says, well, what's that called that you're looking at? So what she's done is change this social interaction where they're having their cup of tea and some dessert afterwards into a confrontation naming task, because she wants him to say the word watch. And he first says, when she says, what's that called you're looking at? He says, So that's a request for repetition. And she does exactly what she's supposed to do. What is that called that you're looking at? Which is almost a direct repetition of what she had said earlier. And you can practice it at home tonight when you, or with a family member, or somebody at a restaurant or a store. If you say, or what, or that person is almost always going to repeat exactly the same thing. And in this particular case, she said the same thing, almost the same thing, when he said, And he answered her question. What? The omega? And where did the word omega come from? Because that was the name that was printed on the face of his watch. So reading aloud, for some people who are living with dementia, in this case, this gentleman has Alzheimer's type dementia, is much better preserved. But retrieval of specifically the word watch is her agenda. But he gave her the answer. What is that called? It's called the omega. But that's not the answer she wanted. This, tapping his watch, as if tapping that particular item has on his wrist is going to help him retrieve the word. She's giving him a boat anchor. She's not really giving him any ramps to help him. This, what is it? What? He looks at her. What is it? Well, it's, as he chuckles, I can't really come up with a word. So now she's going to make it even more challenging, because what she's done now is she's going to point to her own watch. And what does that mean from a cognitive and linguistic perspective? It means that the idea of watch that should be attached to your omega and your wrist, that concept also then needs to be generalized to my different form of object, but it's the same word, which he's having difficulty. So she's thinking that maybe she's helping. I'll give you another cue that maybe your visual watch is not as representative and as good a cue as my watch. And so he answers it. What is this? It's yours. But of course, she's looking for the word watch. And so third time through in this, she says, what? What do you mean? Well, if I sent you upstairs, and in this particular case, there's a clock on their dresser upstairs, because I asked her about this afterwards. So she's now even making more abstract. I'm going to send you upstairs, and they're not going upstairs. So he has to envision going upstairs and having the clock on the dresser, and now having the word clock match up to the word watch, because she wants the word watch. And then at the end, he just says a light, which means just essentially, I don't know what you're talking about, but I'll just give you an answer and let's move on. Which she then finally picks up and says, okay, well, that's it. I guess I'll take your plate and we'll have your ice cream and your cake. So this interaction is an illustration of non-person centered, non-active listener. And so we don't want to do that. There are many other aspects of this woman's interaction with her husband. They're wonderful, but this is one that didn't work so well. Okay, where are we here? Here, next one. So those are examples of person-centered communication that come specific from Kit Wood, and I've given some examples that go along with each of those for facilitation, negotiation, recognition, and validation. I'm also going to go into some other elements and strategies about person-centered communication that are not within that same framework of of Kitwood, but have some relevance. And there is a lot in our literature about reminiscence therapy that really tags into this cognitive component. And I gave you that diagram of the non-declarative and declarative memory. This is where I like you to think a little bit about the semantic memory and episodic memory, because reminiscence therapy is really about reflecting on memories or long forgotten personal experiences from one's past. I'm reminiscing about parts of my life. And so emphasis is placed on remembering these life experiences that were pleasurable, that have particular time points in time, well-marked time points. That means episodic memory, which in some instances can be better preserved for different types of dementia. And what you do is you're giving the person living with dementia some conversational input and control by saying, let's remember that trip that you and I took to Hawaii in 1987. And by giving them the ramp for that, we went with Marinus and Gail on that trip in 19, whatever it was I said. And so you're giving that partner some opportunity to call up from that declarative memory side in episodic memory and to facilitate semantic memory to retrieve these words. And so there's lots of work done by Esther Kim and others on reminiscence therapy, and that can be done with notebooks. It can be done with photo albums as well, picture books, videos. You can even do this in small groups for those of you who are working with the Alzheimer's Society, and not only of York Region, but others. You can do these reminiscence groups, and I'm sure many of you are already using them. And so you can have groups of people with varying different stages of clinical stages of dementia, and that you're going to maybe in setting the scene, you're going to be talking about reminiscence about maybe political events. As many of you know or may recall, Brian Mulroney has died, so there may be something around that because that's a current event, or issues around climate change or poetry or Canada Day. We ran a reminiscence group out at Parkwood Institute here in London many years ago with one of my master's students on poetry, and we had some wonderful expressions coming out from people who would otherwise had not been saying much. And so there's lots of work to be done within the context of reminiscence therapy. And one of the examples I'm going to show you here includes some work done by one of my master's students, Kelsey Dines, who used person-centered communication strategies within the context of an iPad. And so she asked questions about, will an iPad, that is something that has an electronic conversational component to it, increase the use of person-centered care among family members? And does your previous knowledge and familiarity with using iPads, is it because it's the iPad, or is it because of the strategy that you're using? And at the end of the study, did you think that your knowledge of person-centered communication after some training improved? And so in this particular small study, Kelsey recruited 7 persons diagnosed with mild to moderate Alzheimer's disease, in which there were 6 spouses and 1 adult child who were the conversation partners. And they used a particular software program app called Pictello. And in this particular Pictello software program, we included 40 photos that came from and were selected by the person living with dementia and their family member from their photo albums. And I've given you the place to find Pictello applications. I don't have any financial links to Pictello. It's very useful because you scan the photo and it comes in, and then you can type in a sentence that goes along with the picture, and those are co-generated between the person living with dementia and their family care provider. In this particular case, 2 dogs from the student and my other research assistant, the 2 dogs that are in there, and just as an example, and they typed in the dogs play at the park. And what you can do with Pictello also is create these sad sentences, as said before. Simple active declarative sentence in the present tense, a subject and a verb and an object, and in the present tense. And then you can get the person living with dementia or the family caregiver to actually recite those sentences, so that when you tap on the picture or those sentences, the words actually come up and describe that picture. So in this particular study, 7 persons living with dementia and their care providers, we screened them in week 1 to get all their information and how well they were familiar with iPads and person-centered communication. We then had them work with 20 family photos 2 to 3 times a week. We didn't train them in anything about person-centered communication. We want to get baseline. Then in week 3, We trained them in what person-centered communication was, and we got them to choose 20 other family photos, so a new set of family photos. And then for weeks 3, 4, 5, and 6, 2 to 3 times a week, they applied these person-centered communication strategies after we trained them about facilitating and recognizing and validating, et cetera. And at the end of week 6, we then redid the baseline testing on them. And so we transcribed everything that they said. We coded for the facilitation, negotiation, recognition, and validation. And what did we find? Well, this pink line at the bottom, or rose-colored the bottom, refers to the person living with dementia. And at baseline, about 40% of their communication was person-centered. And by the time the study was over, it was up to 45%. And that's the person living with dementia. Whoops. Person living with dementia. This blue line here is the family care provider. At the beginning of the study, they were about 52%. And by the time they got even just into week 3 and week 4, because we didn't, I don't have the data afterwards, but this line goes out the same way. They increased their use of person-centered strategy use over time. And so we could train them to use person-centered communication strategies, and they kept it up over time, and they found it very helpful. So I would suggest that those of you who like to reminisce and go over pieces of information that would be part of episodic memory, the long-term memory you go, that photo albums, you can get the Pictello application online. I gave you the site for that. I'm guessing, I think it's maybe over $30. But then you can use it on iPads, and it becomes a wonderful way of engaging on person-centered communication. Some of the work that was done by Marie Sabunagam, my colleague, and one of her students, were what were some of these communication strategies that support person-centered communication? And so they conducted a study, and it's published now, looking at staff-resident interactions that were audio recorded in a long-term care home, and they recorded usual care routines, helping with dressing, and they recorded 8 staff resident dyads or couples during the morning shift and then in the evening shift. And then they recorded those conversations over a 12-week period. They had 46 conversations, and then they transcribed them and looked for these features. And what they were looking for was what we've talked about before: facilitation, negotiation, recognition, and validation. They want to see, these are some of the features that I've already gone over that are identified as language-based strategies: announcing the topic, repeating and rephrasing, using the types of questions that we want these people to be using. And what did they find? And what they found was that those where there were person-centered utterances only, and not really supportive language ones, 586. And when we looked at all of those utterances, 1,692 had both language-based strategies as well as person-centered strategies. So interestingly enough, people were using these on a regular basis in long-term care, which is very, very helpful. And when they looked at it very specifically, what recognition was, in the recognition category, they're mostly using greetings, affirmations, and rephrasing, and using yes/no questions. For negotiations, they were also asking lots of yes/no questions. When they were facilitating, they were asking yes/no questions, affirmations, open-ended questions, and rephrasing. That was most of what facilitation included. And with validation, they used affirmations. And so what we're able to do then is to identify what are the language features that go along with some of these features that Kitwood talked about. And that was a nice way to operationalize that these were working. Some of the work done by Deanne O'Rourke, colleagues in nursing out at University of Manitoba. I talked to you earlier about their model, but they used video feedback. So we're going to illustrate, we're going to record these interactions between you and staff, or staff and the person living with dementia, and then we're going to give you feedback to illustrate what works and what doesn't work. And what they found was that in these interactions, they did baseline interactions, and then, of course, trained these people, and then did 35-minute video sections back to them about it. And what they found was substantial improvement in the number of care aid statements that got coded that could be useful. They went from 88 to 116. What they call subtotal reciprocity statements, that is, I'm reciprocal to you, I'm matched with you. They went from, and these are all statistically significant, went from 47 to 59. continuity statements, that is, went from 0 all the way up to 5. That is, I'm actually continuing what you're saying. I'm expanding on what you're saying. The number of uncategorized statements, that is something that couldn't be useful as person-centered, they dropped from 42 down to 23, which meant that they're using more person-centered. And so part of all of the education here is video feedback illustrating these examples, and that was work by O'Rourke and colleagues. We also know from some work that one of Marie's Sumundranagam's master students looked at nonverbal elements of communication. So she did a scoping review of studies that looked at and the value of nonverbal communication. And so she started with 1,506 studies, and after doing that, she ended up with 16 studies that examined nonverbal elements in persons living with dementia. And what did she find? She found that many of the studies that talked about nonverbal communication emphasized the importance of eye contact, using appropriate gestures, using the correct facial expression, using touch to reinforce, and being close to these individuals, that is close proximity, and talking to them from front, not talking from behind. What she also found was that when the interaction was successful, the nonverbal elements were appropriate for people getting dressed. The nonverbals were helpful to reduce responsive behavior and to increase engagement and to help people understand. So there were elements of these strategies that I've used, talked about on the previous page, these eye contact and gestures and facial expression, that resulted in fewer communication breakdowns and conveying positive messages. And so lots of studies are illustrating the value of ensuring that your communication, spoken communication, written, comes in with nonverbal elements as well. And so what Emily also then did was to look at whether these nonverbal strategies to support communication demonstrate person-centered elements. And so she looked at a series of studies that were related to interactions and looked at particular language units and pulled out these transcripts from these studies and gathered this information to look at whether these nonverbal strategies were used in the interactions. And so identified person-centered components of the communication, and then nonverbal strategies, and then were the nonverbals actually linked with the person-centered communication. And it turns out that 68% of person-centered indicators had nonverbal communication elements with it. So that then it includes gaze and gestures and touch and body position. So these are a little more detail than I go through at the moment, because I want to finish up with the last sort of phases of today's talk by showing you or describing some novel developments of a program called BEPIC, which stands for an acronym of environmental considerations, person-centered communication, I matter, that is, I is the person with dementia, and then we have the client-centered and abilities. So it's EPIC that matches on with BEPIC. And this is developed by my colleague Marie Sumundranagan, our research coordinator Shalane Baskin, and Karen Johnson, who's the executive director of the McCormick Dementia Services here in London. And so this BEPIC program has components that relate to assessing some simulations with the clients that you're going to work with, providing a survey of their knowledge and debriefing the staff about what these assessments are, training them on specific elements of person-centered communication, training them on issues around delirium, because in long-term care facilities, people who are living with dementia can also have delirium, or those without dementia can have delirium, but that sometimes mimics the presence of dementia. And then in the last part of this program, there's a focus group where they debrief about what they've learned in all these sessions. The value of BEPIC is that when Marie and her colleagues introduced the concept of BEPIC into long-term care facilities, in the pre-training component, there were approximately 60% of the utterances were person-centered. And that was at the beginning of the program for BEPIC. In a control group that didn't receive any training, there were just a little under 50%. And that percentage of proportion of person-centered communication remained the same in the no training group, but the proportion went up in the training group. And so we know that it went just a little below 60% to almost 70% a rise in the proportion of person-centered communication when you do this specific training. What Marie also was interested in is, are there instances when you could have used person-centered communication? And when they did the pre-BEPIC and the post for this, they found that in this blue line, those people who took the BEPIC training program reduced the number of misses and missed opportunities. That is, they used PCC, person-centered communication, more frequently. But with the no training group, it actually went up a little bit. And if we went for a longer period of time, it probably just would have remained stable. So that when you get this information about how to communicate appropriately in this BEPIC training, you reduce the number of times when you could have used it. Interestingly enough, before I go on to the next one, what I want to say is that Marie has developed this BEPIC training program in a virtual reality element, and she's testing that now. And it is phenomenal. I've never been in a gaming person. I don't understand gaming, and I certainly don't understand virtual reality. But I've been immersed in the BEPIC program virtual, and this is one of the employment skills opportunities funds that I'm involved with Marie, and of which she's got substantial amount of support from the federal government to train personal support workers, PSWs, and other frontline workers to actually practice in a virtual reality with Nella and James, who are holograms and representations. And I tell you, when you're in this, you are just immersed, and you're interacting with James and Nella. Nella represents a diversity person, and the language and the communication that's used in this interaction comes from data that Maria and I have collected, and along with Angela Roberts, another colleague of mine, over the decades. And so the AI program associated with this BEPIC crafts these conversations, and it becomes a wonderful learning opportunity. So for those of you who are in positions where you can get your staff to be trained on this, I would absolutely welcome you reaching out so I can connect you with Marie. It's really the forefront, and many of you already may be involved in that in terms of simulations, but this is immersive VR. It's absolutely marvelous. Of course, I would be remiss if I didn't mention that people who are living with dementia also have hearing problems, and as many of you already know, and that hearing loss is really it is the most weighted factor as a potentially modifiable risk factor for the development of dementia. And so we've been looking at the connections between sensory loss and dementia for quite a long time. And so how do you get around some of the hearing issues? And so there are the concept of assistive devices and assistive listening devices, as well as assistive walking devices, assistive vision devices. So I'm just going to give you the general context of assistive device use, but within the context of a hearing loss. And that, of course, sometimes using these assistive listening devices becomes problematic for some people because they don't want to be, especially hearing aids, associated with that because it means they're old, they don't want to use a walker, they don't use a cane. And so we have to get over some of the issues around the stigma, and that's quite pronounced in the field of hearing and people living with dementia. So we know that older adults, that's why I have the OA here, report using hearing aids and some sort of amplifier, whether that's through amplifications at the theater or in their own home with television. And so the prevalence is probably not as high as it should be, but we need more of it. For those who actually who were consulted about their hearing aids, between 23 and 55% who were advised about their hearing aid, 14% received information on other devices, so that not only just hearing, but also vision. And those who had hearing loss, between 8 and 40% reported owning a hearing aid, and then only a very low percentage reported actually using them regularly. And using a hearing aid is problematic, but talk to your audiologist who understands the strength and value of a hearing aid, particularly for people who are living with dementia. And so there are more recent studies that show better outcomes, that we can improve the use of the hearing aids. Of course, they're very costly, although there's some that are coming off the shelf now, and that some people are using them quite regularly. But for those who have hearing loss and who are using hearing aids, there's always this notion of the stigma that I talked about earlier, that those who did not try an aid after consulting with an audiologist saw the most stigma-related barriers. That is, those who didn't want to use a hearing aid had the highest level of stigma. And so we have to try and break down the stigma to make sure that we can make people a little more favorable to the use of hearing aids. And of course, hearing aids make sound and speech louder. That is not only what the person is saying, but also the other environments. And so wearing an assistive listening device, including a hearing aid among some others, improves where you find out where the sound is. It helps reduce some of the background noise, and it improves your sensitivity so people aren't hearing birds and water falling, the leaves rustling, etc. And there are ways in which they have in digitally and computerized suppress the background noise and amplify the speech sound. So of course, there are all sorts of other challenges. I just generally with hearing and aging, I want to go over these, but there are all sorts of assistive devices within the context of hearing. It's not just hearing aids, but there are all sorts of other devices like pocket talkers, alerting devices, devices on your phone, your cell phone that increase the volume and amplification, Bluetooth, etc. So again, I leave that to your consultation with the audiologist who can help troubleshoot the challenges your family members or your staff or your clients or residents are experiencing with their hearing. And there are lots of other oral rehab, AURAL means hearing issues, about what is your knowledge of hearing loss and communication and how to improve that. That's the talker, to use the talker. And then the listener factors. We'll think of this in this case of the person with dementia. What is the impact of their hearing loss? How assertive are they going to be? Are they going to be quiet? And what is their physical and mental status? Part of the oral rehab. What are the background noises? I'm in an office here at the university. There's very little, very few pictures or paintings on the wall, so the reverberation is and reflection is pretty high. There are also the visual factors, as Jamie will talk about. I changed my position so the light is coming on my face. You can see me a little better when the screen's not up there, and how close are you, and what are the distractions. So there are all sorts of considerations to make the environment hearing accessible, including, as I indicated, good lighting, making it quiet, making it well ventilated, and making sure you have these pocket talkers that are just over-the-counter hearing aid devices that you put on the person with dementia. I can tell you my late mother-in-law, I got her on a pocket talker because she had substantial hearing loss, and my sister-in-law and my late wife were absolutely marvelous in working with that to make sure Nona, Mrs. Amadio, was hearing quite well. So I can say that works. And of course, then what are you saying? How are you going to do it? Longer sentences, not great. Using closed set versus open-ended questions. We talked about that earlier. Focusing, giving them choices. Using passive verbs, embedded clauses. All these last three, ixnay. You don't want to do them. So I've put on only what you should do, but also what you shouldn't be using. Okay. And so when you're working with an older adult who has hearing loss or hearing impairment, these are some of the things you need to be thinking about. Is it working? You're facing the person. You want to eliminate other sensory noises. Turn down the television, turn off the television, turn off the radio. Move your back away from the window so you don't have lots of background visual distractions for them. Make sure you loop back to them. And then, of course, using either this listening device or some pocket talker on that. I use this funny diagram that comes from the Livingston et al. Study to illustrate, and I'll just move by quickly, but to illustrate that in this blue section here, these are the potentially modifiable risk factors for dementia in midlife, and of which out of the 40% of the factors that could be potentially modifiable, out of that 40%, 8% of that 40 is hearing loss. So we want to make sure that we get in early in midlife, that could be anywhere from 35 to 60, to make sure that we have hearing checked and your hearing is examined by the audiologist. And so these are the modifiable risk factors that are both minimize diabetes, hypertension, and of course, treating hearing impairment. That is absolutely, because it increases and maintains cognitive reserve, and that's why we think that that's important for hearing. I've also given you a couple of sites from Anthony Levinson at McMaster University, who do some wonderful work on these potentially modifiable risk factors for dementia. It's an education and training program, and I would urge you to take a peek at those. And again, those will appear in the slides. I also want to have you go and take a look at Dr. Susan Lane's whiteboard on video. It's a whiteboard video. It takes about, I think, maybe 3.5 minutes to go through, and it's an illustration of person-centered communication that I was involved in, along with another colleague of mine, Jeff Small from the University of British Columbia. It's an absolutely marvelous video. I've also given you other resources about communication and dementia that come from the Alzheimer's Association in the United States, Alzheimer's Society of Canada, the American Speech Language Hearing Association. And I want to give a plug to my colleagues, Dr. Laura Middleton and Danielle Christman, who are going to give a webinar through the Brain Exchange site. It's on the 28th of March. It's about advancing community-based dementia initiatives, identifying impactful strategies and interventions using the Dementia Intervention Playbook. And I've worked with and I've published with Dr. Middleton, so it's a bit of a push for her webinar that I'm sure you'll find very, very illustrative. So I want to make sure that you have a chance to listen to her about all these community-based strategies. Laura and I worked together when I was the scientific director here at the Canadian Centre for Activity and Aging about using exercise. And as Jamie pointed out at the beginning, exercise improves cognitive performance even in those who are living with dementia. What I want to end up with is a video from the movie Iris. And some of you may already have seen this, or this particular snippet is an interaction between Iris, who's played by Dame Judith Dench, who is a novelist, Iris Murdoch, and her husband, John Bailey, is supporting her and consoling her after they've had a bit of a dust up and had a bit of a confrontation. And he uses many elements of person-centered communication. And so I want you to listen to that in this illustration. And he reads from some of her previous writings, and she responds to that and says, I wrote that. And in the second segment, in the second part of this particular video, I also want you to focus in on how the husband interacts with a psychologist who uses, unfortunately, the collective we. And as this video segment ends, I'd like you to listen for what John Bailey says about making sure that we, as the partners, get to know the language of the person who's living with dementia. And for me, that just captures person-centered communication. So I'll end up with this video, okay?
Not just sorry, but shall I read to you? Shall I? Occupied in observing Mr. Bingley's attentions to her sister, Elizabeth was far from suspecting that she was herself becoming an object of some interest in the eyes of his friend. Mr. Darcy had at first scarcely allowed her to be pretty.
I wrote.
Yes, my darling, clever cat. You wrote books.
Books. I wrote.
You wrote novels. Wonderful novels.
I wrote.
Such things, you special things, secret things. You know many secrets now, Iris. You have shown me a map of Iris's brain world, empty. It would tell me that its hidden mysteries and all the unknown life in there has gone, has been wiped. How then can she say things of such a terrible lucidity? Which bit of the empty jungle does that come from?
We don't know.
You don't know. Don't hide, please. Is it not remotely possible that what Iris says is of some consequence, yes?
Yes, perhaps.
So perhaps we ought to learn her language before the lights go out, what?
The lights will go out.
Yes, of course they will. You all keep telling us that. I know that. She may even know that herself. Not just so.
So that here ends the end of my segment. I hope that you captured in that last video segment that really John Bailey, the husband of Iris Murdoch, read part of what she had written, and that triggered for her a recognition of some of the work that she had done, and acknowledged, and she acknowledged her and validated her, and she then said, "I wrote books, I wrote," and of course he supports her in that. And then the second segment, of course, is in the interactions with the psychologist that he didn't get it. Right? He just said, "We don't know," and no, you don't know, not the collective we, and that you really have to focus in on her language. Yes, before the lights go out. Of course, he focuses in on the negative. We all know that. This is unfortunately a slow, inexorable decline in skills. But if we can change that trajectory, we can by adjusting the line upward a little bit, by supporting it with various medications and all of the wonderful supports that come from the various chapters, the Alzheimer's societies across the province, using, in my case, language strategies and communication strategies, in addition to behavioral elements, that we can make the quality of life of those whom we're providing care for, whom we're paid to be patient for, whom we love dearly, plus our own lives, quality of life, that much richer. So with that, I'll bring it to a close. And I see that there's some questions and chats, and so maybe Jamie, I'll get you to maybe guide us on where you want me to go for the next few
Right.
minutes.
So first of all, thank you so much. That was very empowering, and I'm still kind of in a wow zone from that last video. So thank you for showing that. So
And
all of the questions.
I'm in tears. So that's the other thing. Jamie said, I knew you would be. So
yeah, I've shown that video for a long time for my graduate students, along with that segment by Mrs. Vickers, and they have to actually code that. And so I just find those illustrative of what doesn't work so well and what actually works so well. So just to hammer home the points of what you've raised earlier, Jamie. Okay.
So the questions are in the Q&A. Let me just see here.
Okay.
Right. Can you see the questions in the Q&A?
Yep. Okay. Do you just want me to go through them alphabetically, or not alphabetically,
Sure.
but they occurred? So slide 10, would it be accurate to infer that dementia does not preferentially ravage non-declarative memory? Okay, so as a faculty member, I invoke my two favorite words. One is why, and the other one is depends. So in this case, I'm going to say it depends. It depends on the type of dementia. So for example, if you have Lewy body spectrum disorder or other neurodegenerative diseases that will affect movement disorders, like Lewy body spectrum disorder, amyotrophic lateral sclerosis, and the non-declarative memory includes some motor skeletal movement components. Those are affected, but it's going to depend on the type of dementia. In terms of the non-declarative memory, you don't see that damage early on within, for example, Alzheimer's type dementia. That will occur as the disease moves on, because then people don't become mobile and nimble, and so their musculoskeletal memory, as well as procedures for doing tasks we call procedural elements, also deteriorate. Changing the light bulbs, or doing the laundry, or making a sandwich, which is part of the non-declarative memory. Those will become affected earlier or later, depending on the type of dementia. Okay, I hope that answers for anonymous attendee. Shanta S. said, this is very interesting info. I find that doctors or medical practitioners should listen to this info. Well, I used to teach in the medical school. Yep, here. I find that they tend to have or talk some stereotype behaviors when speaking to older adults. Not going there. My late father was a doctor. I had two uncles that were doctors. I had a brother who's a doctor. I have two nieces who are doctors. So I'm going to. Everybody can learn how to communicate a little better, right? Regardless of profession. So, I mean, there are probably lots of speech pathologists who don't communicate very well. So, anyway, thank you. Love the idea of PCC. Thank you. Shanta says, having had treatment at home during my cancer journey, I've met so many of these types of healthcare people. Wow. Okay. Well, right. And 7 seconds is not too much to ask. Yes, I think, especially in this time when, time management is of urgent elements. And so I think 7 seconds seems reasonable, right? And should be pari of studies for doctors who look specialized field. Okay, got that. Terrific session. Okay, thank you. So not many questions there.
I have one question. I mean, by the way, I didn't get introduced at the beginning. I'm always talking. Sorry. I'm the Director of Programs and Client Services at York Region. And I am so thrilled that Dr. Orange is here. So thank you. He has been a frequent visitor over the decades that I've been here. And I want to thank Jamie for arranging this. She always does these insightful Finding Your Way webinars. And we might have you back again, Dr. Orange, because I think what you have said is crucial for all of us who work with seniors. And for those of us, see my gray hair? I'm 65 in 3 weeks. So I'm officially a senior. I do think that so much of what you say is vitally important. And I'd like my team to be signed up for the Be Epic program. So talk to us at the end about how we do that.
Yes.
Especially if it's virtual, and especially if we can say it's gaming, because I'm not a gamer either, but I think I could get into this. So, I just want to say thank you very, very much.
You're welcome, Andrea. Again, maybe I'm not, the message isn't coming across. You need me again because I'm not really making the message.
No, we enjoy having you here. I always learn something new when you are talking to us and teaching. And we love having you here. So thank you. Goes back a long way too.
Yes, long way. Yes. Jamie,
and I just want to thank everybody for joining, and that as I do get the slides from you, if you are interested in getting the slides, you can email me and I will make sure that the slides do get to you, and just give me a little bit of time to send the recording to the appropriate people that I need to be able to get it through our website. So it might take a week or so, but Dr. Orange has definitely graciously agreed to allow us to put this webinar on our site. So thank you very much for allowing that. I know that the information that you have shared for those who are care partners, those who are caring for the care partners, for healthcare professionals, that all of the information that you shared with us is absolutely going to be put to good use. I know that for myself. I have just been reaffirmed that a lot of the things that I'm going out and educating, that it is relevant and is going to help other people. And I look forward to hearing the feedback from everybody. Tomorrow, you will be getting a feedback survey. So please let me know what it is that you, how you felt, if there's any other questions that you may have for Dr. Orange, and we will definitely make sure that you get the slides. There is one more question in here, actually.
I see it. That? Yeah, it's the issue around the sad sentences, the simple active declarative. Yes. And the example. So I walk the dogs. It's a present tense. I walk the dogs. So, or they walk the dogs is simple active declarative in the present tense. So it's a subject, a verb, and an object, and they're all in the present tense. And so that would be, and there are other examples in the slides that you'll see that reflect a simple active declarative. Again, I don't want to mislead people with that it's a emotionally upsetting sentence. No, it's just it's an acronym we use, a simple active declarative. Okay. Hope that's it. Okay.
Are there any other questions that anybody might have? We have a few more minutes. You can put them into the Q&A. If you have any questions about how to get in touch with anybody at the Alzheimer's Society of York Region or Dr. Orange or any other information. Well, thank you all so much for spending the afternoon with us.
Thanks, Jamie, for inviting me. Same with you, Andrea. Thanks very much. So as people are just signing off, maybe what I'll suggest is, just as a reminder, because I got a couple of things on the go here, just send me an email that you want me to look you up with Marie and her study and see if we can get you onto the training and education component of her Be Epic program, because it's marvelous. It's really good. So it may be a while that she can get in. It depends on where she is in the studies, but I think that this VR component, I had another PhD student years ago that I picked up from somebody else, a faculty member here, but it was a VR program, but it was a 360 for the persons living with dementia. And that was an interesting study. So, but this is specifically for educating and training personal support workers and about how to communicate using person-centered. I think it's the way of the future. So,
well, and that combination of the AI
mm-hmm.
with and the gaming, because let's face it, I'm going to say the younger generation, anybody who's younger than 30 has spent a lot of time gaming.
Right.
I'm making a generalization there, maybe 40. So
yes,
it's the way to go.
Mm-hmm. I agree. So, Jamie, just send me maybe when you send me the feedback from the results, and
Absolutely.
7 to 10 days or wherever it lists, just send me, and I can I'll be reminded to I'll link you up with Marie and her group.
That would be fantastic. Thank you so much.
That's great. I'm going to sign off now. So thank you.
Thanks, Andrew. Appreciate your comments.
Left.
Jamie, I'll send off a notice to you, or at least I'll invite you to this shared folder on the Microsoft OneDrive. Is that okay, or do you have another platform you want me to share that on?